the biggest unmet needs in Alzheimer's disease? Well, the first would be that we really do need treatments that can slow down or stop the disease process. Ideally, we need treatments that can restore individuals to their previous level of functioning, and we certainly don't have those at the moment. We need ways of diagnosing individuals simply with Alzheimer's disease and differentiating between different sorts of Alzheimer's disease and other dementia. And we don't have those simple methods of diagnosis at the moment. And I think that we also need good quality treatments for those things that drive poor life quality for people with dementia. So treatments for agitation and aggression in dementia that don't harm the people with dementia but that do work. Ways of supporting carers and supporting people with dementia through the difficulties of dementia, so the services that people need. We need to understand how best to provide those also. It's very clear that there are problems with agitation in multiple settings. People have problems with agitation in their own homes, in sheltered accommodation, and also in long-term care settings. The problems of agitation are very similar in each of those places, but there are differences potentially in those things that precipitate and perpetuate those behaviours. So in terms of stakeholders, it's tremendously important to be able to work with and to understand family carers for individuals that are living within their own homes, either with or being visited by other carers. In care homes, it's very important to understand the role and the abilities of the leadership and the management of that care home, as well as the delivery of direct nursing care in terms of managing agitation in dementia. In relation to diagnosis, the same things can cause agitation in people's own homes and in long-term care settings, but it's more likely that some things will happen in one setting rather than another. So the congregate living that happens in care homes, where you have a number of individuals, each with their own set of problems, those can cause agitation in individuals. The loss of one's own home can cause agitation in individuals, which isn't the same within one's own home. The diagnosis element, which involves trying to find out what is causing agitation. Agitation isn't a disorder in itself, it's simply a symptom, and we need to find out what's causing that agitation. It may be caused by an underlying physical illness, and there needs to be systems whereby people get that diagnosis in care homes as well as in their own homes, and they may be better or worse in each of those. So we need to understand what's causing that. It may be that there are interactional elements with either your family carers at home or with the paid carers in care homes that are particularly problematic. And again, we need to understand those. And then thirdly, agitation may well be in the eye of the beholder. So we have to analyse what it is that the family carer or the paid carer is finding difficult, and seeing whether we can reconceptualise that so that it becomes a behaviour that is managed and tolerated rather than one that is medicated. In terms of assessment, it will largely depend upon the health service that's available going into the particular place. In the community, one tends to have access to local primary care services who may be more or less interested and more or less skilled in being able to diagnose the problems in dementia. But there are also the supporting secondary care services, be they in geriatrics or in old persons mental health, to support those things. In care homes, in some countries, people in care homes get much less in the way of assessment and care than people in other settings. And in those settings, you can sometimes miss potentially treatable illnesses. So it's very important that a good level of assessment is available in whatever setting a person with dementia might be. treatment success for agitation in Alzheimer's disease depends upon the nature of the agitation. Agitation covers a broad range of symptoms, and what one needs to do is to be able to capture an idea at the beginning of what the problems are, and then on an individual basis to be able to work out whether, when you've finished your treatment, be that non-drug treatment, environmental management or drug treatment, that those behaviours that you have targeted are now no longer troublesome. So individually determining what your outcomes are for a specific behavioural problem is the way to go within this. Now, there are instruments that one can use, but they will just give you a general overview. And I think that when working clinically with an individual with agitation, then it's extremely important to understand that a particular agitated behaviour that the particular person has at that particular time. I think that the trigger point for initiating either non-pharmacological or pharmacological treatments depends upon the severity, the intensity and the range of danger and risk there is in a particular situation. In most cases, it will be the case that the most important thing to do is to find out what the antecedents are of the illness, what is causing the agitation, and that will generally require us to rule out an intercurrent or a new physical illness that's causing those problems, because people with dementia are particularly prone to agitation and delirium with those illnesses. So that would be the first line, investigation. The second line would be non-drug treatment, which involves largely watchful waiting and the management of the things that you have identified that may be causing the agitation. So if an individual is agitated because they're being woken up a time they don't want to be woken up, then you might try a different time to wake them up. If they're agitated in a particular situation of, say, washing or dressing, then you might modify the way that that is done in order to decrease the agitation. So non-drug treatment is the important second step, and that might well involve waiting for a couple of weeks to see if it goes away, because many episodes of agitation are self-limiting. And I think it's only when you have got through those and when you have determined that the agitation is causing problems for the individual with dementia, more than the carers, but certainly causing problems for the individual with dementia, then that would be the stage at which one might consider drug treatments, and then one would consider the lowest possible dose for the shortest possible time, with review to see whether the behaviour has disappeared.